Well, thanks everyone for joining the call today. I'm Nikki Majewski, and also attending from MHCC are my colleagues Justine Springer, David Sharp, and our executive director may be joining momentarily. And from Milliman, we have Brent Jensen, Matt Caverly, and Stodden Davenport. Before we get started with some general introductions all around and opening remarks, want to just go over a few housekeeping items real quick. We look forward to everyone adding to the discussion today and ask that you please mute your line until you're ready to comment, just to avoid any unintended background noise. And if you have any technical issues, please contact Justine Springer. She'll put her email information in the chat. And you may have already seen from the prompt when you joined, but the meeting is being recorded. So we hope everyone's had some time to look over the legislation and the meeting materials that Brent and I sent out last week. But before we dive into the discussion, we'll welcome some brief introductions. So perhaps we'll just start with the providers on the call and then hand it over to Milliman's team. So I'm seeing Dr. Bierman on my screen. Do you want to go first?
Sure. Thank you very much. Appreciate being here. My name is Paul Berman. I'm a psychologist in Towson and work part-time for the Maryland Psychological Association as professional affairs officer. And I'm here on behalf of the Maryland Psychological Association. So thanks, folks.
Who wants to jump in? Dr. Booker?
Oh, happy to. Hi, everybody. Ethan Booker, Chief Medical Officer for Telehealth for MedStar Health. And I asked two of my colleagues, Dr. Bosch and Dr. Shaya, to join as well. I'll have them give brief introductions.
Peter, go ahead.
That means I had to find my unmute button before you. Thanks, Elias. Peter Bash, primary care doctor and currently senior director for health IT quality and safety. And my primary interest, I want to thank Ethan for extending the invitation, is making sure that we continue to have an appropriate and consistent business case for appropriate use of health IT enabled services such as what we now are calling telehealth. Also want to wave hi to David Sharp. David and I worked together, gosh, was that a decade or so ago or more, on setting up some of the parameters and use cases for health IT and EHR adoption in Maryland. So good to see some familiar faces. Elias.
Hello, everybody. My name is Elias Shaya. I'm a psychiatrist and the regional medical director for psychiatric services in MedStar North. And I am actually a former president of the Maryland Psychiatric Society. So in that capacity with the American Psychiatric Association, I worked in early 2012, 2013, and that time on all of the CPT coding relating to behavioral health with the American Psychiatric Association, Maryland Psychiatric Society. So I'm really grateful to Dr. Booker for including me in this conversation here and looking forward to the conversation and doing what I can to help.
Dr. Hughes, want to jump in?
I'm Helen Hughes. I am the medical director for the Office of Telemedicine at Johns Hopkins, and I'm a general pediatrician.
Dr. Berenson, I believe, if they want.
Yep, I've swallowed, and I'm happy to join. I first want to acknowledge that I was also a partner with Peter Bash in the primary care internal medicine practice in DC, where we were together for about 12 years. More recently, I've moved to policy and was in charge of Medicare payment policy at the last 3 years of the Clinton administration at CMS, and have been the vice chair of MedPAC and do my ongoing work at the Urban Institute, especially on trying to fix the broken fee schedule.
Great, thanks. And Dr. Roggio, I hope I pronounced it right.
That's right. So I'm Anthony Roggio. I'm an ER doc over at University of Maryland Medical Center at Midtown campus, but I'm also the medical director of telehealth for the University of Maryland Medical System.
Great, thanks everyone. So I'll hand it over to Brent and he can introduce the Milliman team before I hand it off to David and Ben if he joins for some opening remarks. Great.
Thanks, Nikki. It's great to be here with all of you, and thank you for your introductions and thank you for joining. I'm Brent Jensen. I am a principal and consulting actuary with Milliman. I've been with the firm for almost coming up on, I think, 14 years now, but have done a lot of work in the reimbursement space from both the provider and payer's perspective. And that's, I think, one of the reasons why we've been working closely with Nikki and David and team on this important analysis. I will turn it over to Stoddard. Why don't you do your introduction, then Matt will have you wrap us up.
Sure. Yeah, Stoddard Davenport, healthcare management consultant here with Milliman. I've been focused primarily on the behavioral health space going back to 2010 and have tackled all sorts of topics within that, but have spent a lot of time plugged in with mental health parity issues going back to when the rules first went into effect and evaluating compliance and supporting state compliance monitoring and enforcement efforts and helping assess plans for compliance, and have done all sorts of kind of research and publication and speaking and things like that on top of it regarding kind of the broader issues in the behavioral health space and developments in mental health parity. So happy to join.
And I'm Matt Caverly. I'm a consulting actuary with Milliman. I've been here about 7 years now. And I've spent a lot of time working with Stoddard in the behavioral space of the actuarial world. So looking forward to this, and it's good to meet you all.
Nikki, you're muted.
Apologize. Here we go. So, David, I just wanted to kick it off to you if you wanted to tee up the discussion.
Sure, I'll be very brief. On behalf of our executive director, Mr. Stephan, who is not here at the moment, who will try to join us later, he encourages us all to move on this very important work that we're taking on today. We appreciate the Milliman team for helping us to advance the work related to the study. And we think that you all are the leading experts to really help pull this off for us. So we're very grateful for your time and participation. And with that, let's just move on. So I'll turn it back to Brent.
Thanks, David. So I'm going to start with sharing my screen, make sure everyone can see. I'll bring up the agenda. Really, the focus of today is we're going to go through those 3 files that I shared. And hopefully, I know it's, hold on one second. Let me see if I can get all the videos to show while I'm sharing my screen. There we go. Dr. Booker, I know you had a few other people from your organization come as well. Did you pass along the materials? So Dr. Bosch, Dr. Shai, did you get those? Perfect. Okay, I'm seeing heads nod. That's a good sign. That's one of the things that we'll go through the materials. I'll just start with the agenda. We'll spend most of our time in the technical discussion guide where we have a lot of the questions that we really want to discuss today. And then we will wrap up with going through some of the codes and talk through the discussion, talk through the codes if those are appropriate, the methodology of how we have identified those for the purposes of this reimbursement analysis. And just to kind of recap, the goal of what we're doing here and what we're discussing is trying to evaluate the reimbursement adequacy for really kind of 3 types of services. And listening to your backgrounds, we definitely have the right group here. So first, for behavioral health outpatient services, telehealth services, and primary care services. And obviously there's a lot of overlap between those. But as we've considered those types of services, we're wanting to evaluate the reimbursement adequacy for those specific services. And the first step of that process is making sure we have a good, clear definition of what services that includes. And that's part of the reason why we're going to get down into, in our analysis, we're getting down into the code level detail to make sure that we are identifying the right procedure codes to include in the analysis so we can develop a sufficient comparison. Part of this, I know I'm kicking things off here, but I really do hope that we can get all of your thoughts, and that us on the Milliman side, we're really here to facilitate a discussion. And I know it can be sometimes tricky with doing it on video. I'd so much prefer to do this sitting in a room where you can interact a little more easily. But you know, just if you've got something to say, to let us know. We'll make sure we get around the room and everyone gets a chance to share your thoughts. And really, we're looking to gather feedback on the methodology and the codes that we've shared. So that's the ultimate goal. So we'll start. We've done introductions, general overview of the project scope. I guess I'll pause for just a sec on that overview. Are there any questions of kind of what we're doing and what the goal is of the discussion today before we start to dive into the technical discussion component?
Just in the interest of time, are you having separate discussions around primary care and behavioral health? Should we be focusing on telehealth, primary care, and behavioral health, or should we make any comments related to in-person primary care and behavioral health as well?
Comments related to in-person primary care is also appreciated. That's part of the scope that we're looking at as well. Great question. Any other questions before we dive in?
I have a question regarding the parity, if you don't mind, Brent. I was under the impression that by law the parity is already established, but reading the material here, it seemed unclear to me as to whether or not we are trying to evaluate the need or the justification for parity. Do you mind saying some more about that, please?
Sure, I can add some commentary, and then Nikki, if you have additional insights you want to share. So really the focus is, I guess there's maybe to set a distinction, and Dr. Shai, you may be thinking of like the parity between behavioral health services and primary care services, right? Okay. Really what we're looking at, so yes, that does exist. And you know, the laws are in place around parity. What we're focusing on is evaluating the reimbursement levels across these services to make sure that they're adequate. So it's this question of adequacy is slightly different in my mind compared to the parity. So it's not looking at, are they the same, and are they meeting the requirements of mental health parity law, but it's, are the reimbursement levels adequate? And you know, there's a broad definition which I hope we'll discuss today of what adequate can mean. And you know, is it provided, you know, for the value, is it adequate for the resources required to provide the services, is it adequate? So that's more, it's a little more broad than that mental health parity that we're going to talk about. And I don't know if Nick, you have anything to add?
Sure. Yeah, I think that's a really important question to sort of frame what the real end goal here is. Ultimately, this analysis will inform the development of recommendations in a final report to the legislature that will be considered in the 2025 legislative session. So the current law, the Preserved Telehealth Access Act of 2023, that has a requirement for this report to inform future legislation. So this is, I'll have David jump in here if he wants to elaborate a bit more.
Yeah, and maybe the easiest thing to do is, Brent, if you can highlight or make larger the font, and if folks wanted to look under the background section, that second sentence, and if you want to take a moment to look at it, it says, yeah, the studies will examine payment levels for somatic and behavioral healthcare services delivered via telehealth and in person. And on my agenda, which may be a little different than yours, let me just read this. It says the framework will benchmark reimbursement for private payers and Maryland Medicaid for primary care and behavioral health outpatient services to the current Medicare physician fee schedule, based on an analysis of the data from MHCC's all-payer claim database. So that's kind of the intent of what we're trying to do here today, and we're working on with this particular project. Is that helpful, or is there something still missing? I think Dr. Booker, you have your hand up.
Yeah, that is helpful. I guess I have what I think I read in the meeting materials in terms of preparation, in terms of that payment assessment and payment levels was as a percentage of Medicare reimbursement. So not attempting to resort the sort of rank order of reimbursement that is already kind of encoded in the HCPCS categorization, but really trying to understand what the percentage of appropriate compensation is or payment is relative to that already established relative value scale that exists in the CPT structure. That was kind of one question. And then the second question is payment levels, meaning what exactly? Is that about work RVU payment levels? Is that about practice expense? Like, what are the boundaries of that payment level? Because there's the payment level that a
There's
provider might understand as a work RVU, for instance. And then there's the payment level payers really looking at, which is usually total payment, which is encompassing not just the work RVUs, but also the practice expense or facility costs or other things that are part of that total bill. And I just want to understand what it is that we're talking about here.
Yeah, right. And I'll let Brent jump in a moment. I think the first part of what you mentioned was spot on. You know, we're looking at it as a comparison. I don't believe we want to necessarily get into defining whether the RVUs for the three major components is correct or should be increased or decreased. We're trying to get a general sense of, if you compare what the payers pay to a provider in totality for a specific CPT HCPCS code, how does that relate to what they would receive under the Medicare physician fee schedule as a percentage? And so Brent, you can weigh in here, but I also suspect some of the commenters, Dr. Berenson, who has been around in this space for quite a while, he might have some feedback. Dr. Berenson, is it appropriate to jump in now, or do you want to follow up? And you're muted, sir.
Yeah, I have to get back in the swing of things. I was going to hold this till later, but the way this conversation has gone, I just want to say it now, which is that I hope we're not assuming that the payment by Medicare for primary care is appropriate or adequate. It isn't.
That's correct. There's not a determination on the appropriateness of the Medicare physician fee schedule, because I don't think we need a study for that. I think we could just pick up the phone and everybody would pretty much be on the same page, which is to your comment.
Yeah, okay. So I'll just make my comment now, and because it's the work I'm currently doing, is that at least 25% based on research, and probably significantly more of what primary care physicians do during their clinical day is not compensated at all. It's not paid for. There's no codes for the whole range of activities, or at least no codes recognized for payment. And so that may or may not be the situation for behavioral health professionals, but it's just the reality.
Yeah, and I think some of that will get ferreted out in the study that our folks from Milliman are doing. But yes, these are the kinds of things we're hoping that you all will express. There isn't, for lack of better words, any bad or inappropriate thoughts here. The only way we get to the center of these issues is you all opening up and just sharing with us what you feel, what you believe. And Brent, I'll turn this back to you.
Yeah, and David, just to highlight one thing that just came up there is the reason for putting everything on a percent of Medicare basis, like we said, it's not to say Medicare, 100% of Medicare is the right value. It's to put everything on a consistent basis so that we can then look across services and have an easier comparison. If we know everything's on a percent of Medicare basis, then we can look and see, oh, this is 150 versus 175% of Medicare. That's more the comparisons that we're doing, and the reason for putting on that percent of Medicare basis, as opposed to compare to the Medicare fee schedule.
And
so just to reiterate that.
Yeah, and to Dr. Berenson's point, I sort of knew how his thoughts are, because we've worked on a lot of different policy groups together over the last several years. But it gives us a way to benchmark, because then we can come back and say, look, if we're 25% off from the Medicare physician fee schedule in theory, and we think the fee schedule is off by another 25%, now you have something for policymakers to begin to think about.
Great. Dr. Berman, I saw you had your hand up at one point. Did we answer your question?
Absolutely. My point was the same or similar to Dr. Berenson's point,
Okay,
which
great.
has to do with the adequacy of payment and the question about why we were pegging things to Medicare, but I understand the reasoning. Thank you.
Yeah, it's the tide, if you will, that we needed to be consistent.
And as a little bit of context too, in the healthcare space, often when we are doing reimbursement analyses for a number of our clients, we will often look as a percent of Medicare just for this reason of creating consistency. And that it creates a circumstances where we have an apples to apples comparison, can start to look at reimbursement in a more meaningful way than we otherwise could if we were just looking at the dollars. So
And there'll be some room in the recommendations in the final report to note these kinds of concerns that Dr. Berenson and Dr. Berman and others have sort of call out already.
perfect. All right. Well, with that, let's jump into the technical discussion guide. And I think you still see the agenda. Is that right? Okay.
Yes.
Let me reshare how we did this. All right. Now, do you see the technical discussion guide? Perfect. So we've already started to dive into the methodology review and really so we've given the background, kind of the purpose, why we're using percent of Medicare. What I want to start to shift towards and get the group's thoughts is how we've identified this set of codes, right? We're talking about behavioral health, outpatient services, telehealth, and primary care services. We want to make sure that we've listened to all of your input and experience to ensure we've got the right list that's going to be most applicable as this report and analysis gets used in legislation going forward. So to give some background, we send over the detailed list that's in the Excel workbook, and we'll look at that in a minute, but wanted to talk conceptually about the methodology here. And listed out the steps. So first step was we tried to identify the appropriate HIC picks to include in the analysis, and we outlined in the workbook how we did those. It was a mixed process, if you recall, where we used the Milliman Health Cost Guidelines, which is based on Milliman research that's been done for decades to group services, group HIC picks into certain service categories. And leveraging that research, we rolled up the HIC picks into first a primary care, the PCP codes. And one other consideration that we had is we wanted to ensure that it was only PCPs. So when we looked at the specialty codes or the specialists, we ensured that it had to have a PCP or specialist to be considered in our code list. So that's the PCP codes. When we look at behavioral health, we looked at the E&M HIC picks and ensured that the specialist was either a psychiatry, general psychiatry, or neuropsychiatry, and have also flagged some codes in this list, and actually all these lists, that potentially could be excluded and help facilitate our discussion today. In these E&M codes, we excluded ones that referenced either some sort of inpatient stay, considering those out of scope of what we wanted to look at. And then the behavioral health codes more generally, again, using the Milliman Health Cost Guidelines to create a starting list, and then reviewing what those were to identify potential ones to exclude as well. Dr. Berenson, I see you have a question.
Yeah, I don't understand why you're limiting the behavioral health professions to psychiatrists when the large majority of services, especially therapy services, are provided by psychologists and social workers and probably some other professions. If you could explain that.
Well, that's a great insight. Stoddard, do you have some thoughts on that?
Yeah, no, I think the the intent was only that the provider type would be limited on the E&M codes specifically because the E&M codes have to be billed by a physician. All the typical coding used for psychotherapy and a huge range of other outpatient behavioral health therapy services would not have a physician psychiatrist restriction on them.
So I understand. I would point out that the general E&M codes, I assume you're referring to like the 99211 to 99215, can also be billed by nurse practitioners and physician assistants at 85% of the, and they get 85%. Your point, if that's correct, that's fine. So if it's a therapy code, then there's no problem. That's not restricted to a psychiatrist.
Yep.
Okay, that helps.
Dr. Berman?
Yeah, so a follow-up to that has to do with health and behavior codes, and I really did not have the time to look through all of the codes that were included. But a quick look suggested to me that health and behavior codes were not included, and some testing codes, neuropsychological testing, psychological testing, at least my quick view again, suggested they were not included. So did I miss them, or is there a reason for their not being included?
Yeah.
Because certainly health and behavior codes are a significant part of what mental health professionals, psychologists do in terms of working with individuals with healthcare diagnoses, medical diagnoses, diabetes, weight loss, et cetera. You know that.
And just to the Milliman team, if we're hearing questions from our participants that we're unsure that we have a good answer for, yeah, I would put it on the list of things to follow up on, because maybe it just means we need to go back and take this great content that we're hearing and go, oh, did we miss something? Should we include it? What was the rationale? As opposed to, we might not know the answer to that at the moment. And these are the kinds of feedback we're hoping to hear from everyone.
Absolutely. And David, just elaborate that a little bit more. So Dr. Berman, your context around why you're considering those codes important, that's the helpful insights and will give us some good takeaways. Because really this, like we kicked it off, this is not intended to be, here's the list that we're going to go with. Here's the list we've started with. We want your input and insights so that we can make sure that the final list where we end up is the right one. So appreciate that. And I think Stoddard, maybe just given that it wasn't jumping off the page too, we'll take a look at those codes in particular as we continue to refine this.
Yeah, I mean, the one thing I can chime in with real quick is I think we do have a handful of sort of screening, diagnostic, evaluation, assessment flavored codes in the list. I think where we're likely missing health and behavior codes right now is where they're for services that are not sort of explicitly tied to a clinical diagnosis for a behavioral health condition. Like if you're thinking about, like obesity management, lifestyle modifications, anything related to that where it may not necessarily explicitly be tied to a behavioral health diagnosis. Those are things that we probably would not have included right now, but for sure, open to the feedback if that seems like that's something that makes sense to include here.
Yeah, no, I was thinking about codes that were related to physical diseases, treatment of epilepsy, cystic fibrosis, GI disorders, those kinds of things.
Gotcha.
Perfect. Thank you, Dr. Berman. Dr. Bosch?
Yep, thanks. So first, a more general question, then a specific one. What feedback exactly are you looking for from us on the code set list? Are we ready to say this looks like it is mostly representative of a code set for behavioral health or primary care? Or is this, I think you already said, we're not looking to have our stamp of approval that this is the complete set. So every possible code that could be used. So am I correct in that?
Yes, yeah, how you outline that is right. Well, and I want to explain maybe one additional step that I think will give a little context to your question there, is once we have this code list, as we talked about, we're going to apply this to the all payers claims database and look and see, we're going to look at actual utilization and costs for these services. So to the extent we look at it and some of these codes are less utilized, that's going to be something we're considering as well. So we want to make sure we cast the net wide enough so that we don't miss any meaningful codes that are utilized. And then as we do the analysis and intentionally need to narrow it down, I think, to make it digestible, we want to make sure we cast the net wide enough to start that we didn't miss meaningful services or meaningful codes in our comparison and our analysis. Does that helpful context?
Yeah, I think so. I mean, I would also think that just based on pulling things from payer databases, you should probably be able to get what you're looking for without us, which is, for primary care docs or behavioral health clinicians, these are codes used, 80+% of the time or 90+% of the time. And then if you're, asking us as people with subject matter expertise, does it pass the sniff test? Is there something that we miss just by doing a data pull? That certainly makes sense to me.
Perfect. Great.
Okay. One other question on that. As you're introducing the code sets and saying like, well, we want to make sure we got primary care codes and differentiating them from specialists. I mean, I think you sort of do that, but I would frame it differently. Your code sets are looking at non-procedural codes. So, it's the same cognitive services, E&M type services that specialists would use as well. I think that's what you meant, but I just want to say that part out loud to make sure that I was looking at the same way that you had intended us to look at it. Okay.
Yes, I think
I see you nodding your head.
Yeah,
okay.
perfect.
Thank you.
Dr. Shire? You're on mute.
Yes, thank you again. I would like to reiterate the point Dr. Bash made, which is really a critical part of this work group to use the time efficiently. If you get your databases to inform us, because this is a very, very long list of codes that would be kind of difficult to screen through. A point to point out here, just an example in your Excel spreadsheet, in the tab that says BH codes, if you go down to line, let's say just for the sake of conversation here, line 208 and below, most of these, and many above them as well, but most of these are very old CPT codes that are no longer in use. And I'm sure there are many other similar examples if we were to go line by line.
Right.
That would apply in the same way, that would allow us to take these things out of the lists that you have if we follow what Dr. Bash was suggesting.
Yes.
And then we can come back and more or less determine on those codes that are indeed being used regularly the merits and the specifics that you all were bringing up earlier.
Absolutely. And yeah, the intent here, we're not going to walk through the detailed, we sent the code list for reference. The plan is not to walk through code by code. We've got much better things to do with our time than walk through 1,000 CPT codes and hit things today. So sure, we're not going to do that. I actually do, in light of that, and kind of shifting a little bit back towards the questions that we outlined, because I think we got stuck a little bit on the methodology and the code list before we were able to talk about some of these higher level questions. I do want to shift and think a little bit more and get the feedback from the group about the methodology overall, right? I gave some of the context, wanted to make sure we had the details there, and it sounds like we're getting to a better understanding. But let's jump to this question. Actually, Dr. Berenson, I see you've got your hand up. Let's maybe take your question or comment, and then I want to shift gears to tackle some of these questions just more generally about the methodology and get feedback from the group. So Dr. Berenson, you're
I
on.
just wanted to sort of bring a little more detail to the last conversation. I agree completely there. When I was looking at those alphanumeric codes, some of those are tracking codes which don't have payment associated with them by definition. Some of them look like they're in demonstrations, so it would be really useful to clean that list by looking at actual spending.
Yeah.
Very soon, so that we're not over. I mean, even though we don't have to go through code by code, it would simplify, I think, the sort of the scope of the work if we had a list of just the codes that Medicare pays routinely for.
Absolutely. And Nikki, correct me if I'm wrong on this. I think the plan is to, between gathering this initial feedback, we should be able to get into the data and have a follow-up stakeholder meeting where we'll be able to look at some of the narrowed list. Is that correct, Nikki?
Yeah, so as soon as I believe that your access should be in soon granted, so that you can do that analysis, and we'll be in touch with the next version of this list.
Yeah.
And
Yeah, the other thing I'll throw out too, as far as the list, I mean, we on our end maintain sort of a master code set that we reference for a lot of work that includes all the old expired codes, mainly just for the sake of thoroughness. But yeah, I think a lot of those are going to fall out when we look at the data. I will say though that when you try to compare actual real world claims data against the official coding guidelines and rules that are out there, it can be surprising sometimes how often folks are very behind the curve on syncing up with the latest and greatest requirements. I still occasionally see pockets of payers that, for whatever reason, have not stopped their providers from using old codes that went away in 2013 for psychotherapy and other services. So, but yeah, I think those are more than likely going to fall out when we pair this with utilization numbers.
Perfect. Thank you, Stoddard. Dr. Bosch?
Yep, thanks. So are we moving now to the like highlighted question?
Yes,
Okay.
that's where I'm hoping. I was wanting to make sure everyone has a chance to share thoughts as they're
Yeah.
but that's where I'd like to go next, is talk about
Great.
What, and we started to talk about this a little bit when
Yeah.
Dr. Brooker, you were talking about RVUs in particular. Like getting the group's thoughts on what payment adequacy is, what that definition is.
Okay. So again, gosh, this is probably used to asking doctors questions who answer a question with another question. Sorry. But I'm gonna do that now. And again, just being invited yesterday to the group, I tried to skim through the material, and I probably didn't do it justice in terms of having a thorough command of this. But my question would be, you could look at payment adequacy in a number of ways. Are you making the docs happy? Are you considering the environment in the state of Maryland? And I'm going to make up a figure because I don't actually know the answer. If most primary care doctors were employed by health systems, as I am now, I wasn't when Dr. Berenson and I worked together. The question's different. How much does payment have to be for primary care for them to employ primary care doctors, which might be considered a loss leader or something they're willing to accept less than adequate payment for. So as you're looking at payment adequacy, to whom? For for the state of Maryland to consider, for the people of Maryland to provide services, to kind of keep to a balanced view, which the stakeholders, which include the physicians and clinicians we're talking about, health systems, the market. Otherwise, answering that question is going to be really, really difficult. There are lots of models for looking at what's considered adequate. So if you could give us more of a lens of how you're trying to conduct this, and who the audience is, who's ultimately going to say, you've answered our question. And I'll stop.
No, that's a great question. And that you described it very well, and that answering that payment adequacy is a challenging question. And I don't think so. While we're looking at, I guess, to give a little more context to this question, right? We talk about payment adequacy and payment consistency. Payment adequacy are the kind of thing overall, are the levels at the right spot. Payment consistency is when I compare this to this, are those relativities right? When I compare two different payments. And really what our analysis is setting it up for is we're setting up the process or the framework to, one, answer that consistency question, and then as the definition it evolves, and as that gets decided upon by broader organizations of what adequate is, then the framework will be there to say, okay, yes, here are the adequate levels. So our intent with our analysis isn't necessarily to say here is the end all be all definition of what adequacy is, but to develop that framework for being able to evaluate adequacy using reimbursement as a percent of Medicare.
So thanks for that. If I could just give a follow-up, please. You kind of answered my question. I mean, I certainly understand the difference between the two. That was not my concern. And payment consistency is certainly something that we can study and look at the data, say, okay, we're all satisfied with that. But if you're asking for us to make sure that we give you a thorough enough catalog of methods for determining payment adequacy, I'm sure we could do that at some point. Probably not finish that work today, but it sounds like we don't need to answer that question for the purpose of this project, that you're just looking for a catalog of methodologies so that whoever the audience is for this final report can say, here's how we're going to determine adequacy, whether it's 125% of Medicare, or someone else, or someone taking a more Machiavellian approach, which is adequacy is just, a penny above the level at which primary care doctors and behavioral health doctors leave, or are threatening to leave, which happens all the time. I mean, there are a lot of ways of, I'm being serious. There are a lot of ways of looking at that. And I want to make sure that if we are spending time and effort on this, that we're giving you all what is useful and not spinning our wheels coming up with something that is, going to essentially be, we'll put that in the appendix, but that's not really the purpose of what we're trying to do.
Right. Yeah, no. And it is, I describe it as, we want to make sure we can describe the considerations for defining payment adequacy. But like I said, the focus is going to be on setting the framework for evaluating it, not setting the definition. So really, if we spend a few minutes here just getting thought, I mean, you started to share some of them, Dr. Bosch, of important considerations in defining adequacy and approaches. I think that's what we're hoping to gather in maybe the next few minutes here, and then we can move on to some of the additional questions that get more into the details of the methodology that are going to help us refine the process.
Brent, is it fair to say that there could be multiple approaches considered, and then the group of experts here might come back and say, of those approaches, we think this one is probably a more reasonable approach given the environment in which we operate in today?
Absolutely. Yeah, certainly that's a way we could go about that. Thank you, David. So we've got Dr. Booker.
Yeah, I actually just wanted to bring back the question again about scope here, because as David pointed out at the beginning, in this original framing, there is at the top of this, the studies will examine payment levels for somatic and behavioral services delivered via telehealth relative to in-person care. So it's not payment adequacy in totality, which is more than we could handle. Are we talking about payment adequacy for telehealth services in a way that may be distinct from, or what other components, what other things need to be considered when thinking about payment adequacy, given a modality difference, not in totality? So I just want to understand, is that the question we're trying to answer?
Yes, that's a great clarification. Yeah, so if we look specifically at the telehealth versus the in-person services, any considerations that the group would have or thoughts around what should be taken into account when defining adequacy for those telehealth services?
And I think they are considerable. And I'm not sure that they vary by code set or by CPT code as much as they vary by other things, such as the workflows associated with the practice expense of delivering the services, right? And so the adequacy of payment for services delivered when you're a primary care provider or behavioral health provider who's in your office periodically doing telehealth visits in between other things is very different than the overhead cost of other types of workflows. But they're not CPT related variability. They're actually practice location, setting, and business model variations that are more captured in the practice expense side or the facility cost side than they're practiced in the CPT or work RVU variability.
So, Dr. Booker, isn't it sort of all the above that you mentioned? Because by looking at the adequacy in totality, then you can sort of step down and then do a sub-comparison of telehealth versus in-person care. And then at the same time, you have an opportunity to use somatic and behavioral. So it feels like what I hear you describing is sort of, it has a couple different layers as opposed to just being, it's a binary approach, one or the other.
Oh, it absolutely has. It has, to my mind, has at least 4.
Yes.
In terms of practice expense variability. But again, I think the whole point here that I'm trying to make is that the payment adequacy and variability is practice expense side, not work RVU side, because I think many of us have maintained for a long time that actually the fee-for-service system is not great for a whole bunch of reasons, but it is pretty granular in describing the work that's done over an encounter period that has a beginning and an ending, and someone's doing something in that encounter. It's pretty good at defining time and intensity of services on the work RVU side. And I don't think you need to actually do anything different for telehealth for that. It's adequately described on the work side, but it's not at all adequately described on the practice expense side.
Perfect. Appreciate that. That's a great insight. Thank you. Dr. Berman?
Yeah. So I was thinking about payment adequacy as very much connected to network adequacy. I guess I think about payment adequacy as the rate at which a sufficient number of providers are willing to join and be on network panels in order to make network panels adequate. Because we know now the vast majority of psychologists anyway, and certainly even more psychiatrists, are not willing to be on the panel because of inadequate reimbursement. So somehow, if we could tie those two and figure out what adequate rate is to be able to get people to make networks adequate, then we'd have an adequate reimbursement rate.
Perfect. No, I think that's a good thought as well. Stoddard, I'm trying to think, we were chatting, I think, a little bit about this the other day. Do you have any follow-up thoughts to Dr. Berman's comments there?
Yeah. Yeah, I mean, I think it's interesting to chew on how much that perspective ought to feed in here. I mean, the the aspect of this that starts to get, a lot more nuanced real quick is if we're thinking about it from that lens, this kind of becomes a little bit of a macroeconomics question too, of, how are we solving supply and demand problems?
Mhm.
We know that, like, overall in aggregate across the nation, we have significant shortages across all sorts of specialty types. And so, is it a level that would induce folks to relocate? Is it a level that induces more folks to go into professions that are understaffed? Is it a level that, so those sorts of things play into. I think maybe it's good to chew on how far down kind of the macroeconomics rabbit hole do we want to go with this whole conversation as well, because that certainly plays in from that lens.
Perfect. And just so Dr. Shia will come to you in just a sec. I do appreciate the comments, because as I'm looking through kind of all the questions we've got in this section, I think we're covering all of them. So I don't think we'll need to walk through them one by one. We are kind of talking through different methodologies and other focuses that maybe we should consider here. So I appreciate the comments. I think we're covering the insights that we were looking to gather from this section. So thank you. Dr. Shia.
So I do want to once more reiterate the point Dr. Berman and Stoddard made. I think it is really critical, in part, to evaluate the database, not only for what codes are being used, but also for the panel's adequacy. That is a most critical part of determining adequacy of reimbursement. This whole project is to determine adequacy of reimbursement. And if you find that virtually nobody wants to be a part of the panel, that's a clear-cut answer that there's no adequacy in that reimbursement. And I don't think we should sidestep that question. We may not have the answer, but we do have observations related to that question, and that should be included in the report.
Yeah.
The second piece that I also want to elucidate, relating to also what Dr. Booker said, as far as the adequacy and consistency and the nuanced definitions, that will frequently depend on the specific code itself. To answer that question specifically or appropriately, it has to be answered specifically relating to a code. So, for example, an E&M code visit in comparing telehealth to in-person may very well be the same, and there would be parity between the two, or there'd be the same for many aspects of what the determination of cost would be, whereas doing neuropsychological testing would be completely different in that regard. The third piece is that it is important to keep in mind that most operators, most providers, are not going to have purely telehealth or purely in-person types of visits, and therefore the overhead and the expense and the structure of the operation is not either or. It's most often, especially for those who are participating in various insurance panels, most often, I would say practically 100%, is going to be both. And that is important to take into account. I don't think separating them would be realistic. Thank you.
Thank you, Dr. Shia. David, did you have a comment you wanted to make?
No, I think at this point I'll just hold. So just
Okay.
for the group's information, our executive director, Mr. Stefan, has joined.
Welcome, Ben.
Thank you. Sorry, I'm a bit late, but this is an important conversation, so I'm glad I could join for about half of it.
Perfect. Well, we're glad you could make it. Dr. Berenson.
Yeah, I have a few points I'll try to make succinctly. First, I want to just point out what I think a lot of you understand, maybe all of you, but it gets forgotten in the conversation, is that the Medicare fee schedule is based on relative resources, not absolute resources. So the practice expenses may or may not reflect actual cost to a practice. It's the relative costs is what it does. So is the whole fee schedule overvalued or undervalued? If they're relatively correct. So that gets forgotten, and so it becomes, so you need some external factor to determine whether it's adequate. The second, I'm not opposed to the concept of considering whether physicians are willing to participate, whether in a network or in Medicare. It just happens that by far the leading group of opt-out doctors in Medicare are psychiatrists. Whether that's a problem or not is a different question, based on the nature of their practice and their ability to attract affluent patients who don't need Medicare to pay for their therapy. I think it is probably a reason why psychiatrists don't do much therapy in Medicare. Many psychiatrists don't participate and have actually opted out of the program. So what MedPAC has generally used, they do look at the sort of adequacy of the the professions who are participating, but I think they rely much more heavily on a different form of a market test, which is, do beneficiaries describe problems with access to needed services? I don't think they particularly emphasize behavioral health services, but probably should. And in fact, people have suggested that there's a methodology problem, because what people know anecdotally is that there's many parts of the country that have an inadequate supply of primary care docs. It doesn't show up in those surveys. So maybe that they need to be more sophisticated, more granular, but that to me strikes me as a real market test that should be a fundamental one. Do the subscribers or the enrollees or the beneficiaries have access to the care that they need? Would partly determine whether the payments are adequate. And I would make just one other point, which is clearly is related to telehealth and other forms of non-face-to-face communications, is that is the factor of billing costs in relationship to payment. In 2019, Medicare adopted something called a check-in phone call, in which physicians could call their patients to determine whether they needed to come in for an office visit. It was paying for a phone call, basically, prior to the COVID public health emergency. And the fee that was created in line with relative values, both practice expense and work, was something like $14 and change. And the one study I found that assessed the billing costs for billing for an office visit, which is not that dissimilar, was $22 or $26 or something like that. And guess what? Nobody provided that service that year. There was $200,000 of spending in the entire country for that code. So that complicates the situation, because I presume that certainly in primary care, and I know less about behavioral health, but frequent short communications, whether by video or by phone, might result in a relative fee that is inadequate in relationship to billing costs, and almost nobody considers that in designing a fee schedule. Sometimes the right fee is not one that will generate work, will generate the service being provided, I guess is what I'm saying. So it gets a little complicated.
Well, that's a great insight. I appreciate that. Dr. Bosch?
Yep, thanks. So I appreciate Bob's comment about access as a way of looking at is our payment adequate? Probably a little bit more so than people joining a network. And here's why. And I referenced this point in my initial comments. Joining a network could be something that people see with a provider new in practice, or someone willing to, well, let's see how it goes, and you join a network. Will you stay in the network? So to me, it's more important to look at network sustainability rather than can you convince someone to, hop on for the first year. And the other part goes to my comment about how to isolate that in an environment where an increasing number of our doctors are employed and other clinicians are employed by health systems. Your health system might say, look, this specific, and I prefer the word payment to reimbursement. I think I put that in chat. Payment for behavioral health and primary care services. That's what it is. A lot of people might consider it inadequate, but in a sense, and I'm just saying this as conversation, I'm not saying so what, because I believe so what, but if the health system has a reasonable financial relationship with payers, then you're an employee, we're signing you up on the network. So what would you take from having a whole network of primary care doctors now in your network? Does that mean primary care payment is adequate? Not necessarily. You have to look at it in the setting in which it's applied. If it was a cleaner market and clinicians were all in business for themselves, then you could look at people signing on to networks as a decision made based on finances, need for new business, and so forth. I think that's, and maybe David, you could fill me in here. I'm assuming in the state of Maryland, I don't want to speak for behavioral health, but for primary care services, certainly a majority of docs, if not a substantial majority, are employed by large practices or health systems.
I think that's a correct statement to make.
Okay. Thank you.
Thank you, Dr. Bosch. No, these are great comments. I think too that, that consideration of access versus joining the network is helpful to hear, and helpful to hear your perspective on it. I do want to make sure we have, just kind of watching our time, make sure we have time to jump down to some of these code list questions. So to wrap up kind of our conversation about the overall methodology and our approach of understanding that definition of adequacy is not something we're trying to necessarily solve or create a universal definition for on this call. But our approach for creating a framework to help evaluate that, to look at various definitions, approaches, and have considerations for adequacy. Is there any last thoughts on approaches, how we might look at this differently than what we've outlined here
And
that
Brent,
we should consider?
yeah, and Brent, while the others are teeing up their thoughts here, I would invite Dr. Hughes and Dr. Roggio, sorry if I'm incorrectly pronouncing your name, sir, to weigh in. I'm certain they have some ideas or thoughts, and we want to make sure we get as many folks to weigh in as possible. Dr. Hughes, any thoughts?
Oh, sure. We've thought about this a lot, and I'm not as familiar with the adequacy discussions more broadly, but I guess simplistically, I sort of see it as what is the current state, at least for Medicare, which is the non-facility payment rate, which I guess would be, if you did $1, the facility payment rate is 80 cents and the non-facility payment rate is $1. So right now we're receiving a higher payment rate, regardless if it's a facility site or a non-facility site. And so the question federally will be, do we do anything different after December 31st, 2024? Is there a facility rate payment, so 80 cents on the dollar plus additional? And then how do you, to what others were discussing in this hybrid care environment, it's very hard to put a dollar number on what is the overhead of telehealth, because telehealth varies greatly. So I guess one way to frame it for the Maryland legislature is in buckets of options to make it more simple. There's what we do currently, which is to pay the non-facility rate. That essentially gives you the same overhead as a non-facility practice. Or you pay the facility rate plus some amount, and then describing the buckets of what those amounts could represent. Or you pay the facility rate, which will essentially value at zero the overhead, because my understanding is, at least for now, there's no facility payment. I know it's complicated because of the global budget system, but those are some of the three buckets in my mind for professional fees: non-facility payment, facility payment rate plus some amount, versus the facility payment with no additional overhead amount. And I guess what we see on the ground in a hybrid system is that any system we have a bottleneck of providers and we have a bottleneck of specialists. So any system that is going to not be parity is probably going to sacrifice telehealth access. So I think that would be another point for the legislature to understand.
Excellent points. Thank you, Dr. Hughes.
And I'll second Helen's talking point there, which is even within our own system, where we have so many facility-based providers, they have, and a lot of times, actively been discouraged from using telehealth by their higher ups because the payment is not, or the reimbursement of the payment is different compared to their non-facility counterparts. It doesn't cover the overhead that they would otherwise get covered if they saw the patient in person. And I think that's kind of the key piece here, is we have to make sure that we're covering the costs at the bare minimum. And if we can't do that, you're going to disincentivize telehealth, and it's going to see a significant drop off. So whether, to that point, whether it's the facility plus model or something else, I think Dr. Hughes' points are perfect.
Perfect. Thank you, Dr. Hughes. Thank you, Dr. Roggio. Dr. Booker.
Absolutely second to Tony and Helen's perspectives on this. But curious if, as part of this work, understanding the novel costs of telehealth delivery for a health system like our collective health systems is part of what's necessary in addition. Because I think even understanding an order of magnitude of the kinds of costs that are required to actually deliver care is kind of part of the challenge here. So in an open forum, because of the contracts we have with technology vendors, Dr. Roggio, Dr. Hughes, and I are not at liberty to tell you how much we pay for this stuff. But in other methodologies, we may be able to tell you in aggregate what we have to spend on platforms and support to provide an equitable, secure platform out into the world, and it is net new cost relative to what we've been providing previously. These are people and platforms and costs that we did not have in 2019 that we now essentially have to have.
Got it. And just to clarify, when you're reiterating what you're saying, make sure I'm understanding, these novel costs that you're talking about you're thinking the technology costs for being able to actually have the telehealth visit.
I'm talking
they
about
were coming into the physical building before, right?
Correct. I'm talking about tracking. If you think about what are the components of let's take the non-facility setting, just because for practice expense, non-facility is actually easier to think about. Practice expense for delivering an E&M service has components that include staff, a blended staff, that's non-billable staff in your office who's providing things, and then real estate cost of that space. That's what practice expense is supposed to be. And practice expense is supposed to be incentive neutral based in CMS conception of what it is. So there's a realist. Go ahead, Helen.
I was just saying, to piggyback, the other way to think of it is the reverse costs. So what are the costs that you need for an in-person visit that you don't need for telehealth? Which is mostly like an MA taking vitals and the time the patient is physically sitting in the room. But almost everything else, the scheduling before, the MyChart messaging after, almost everything else is shared. The telephone being live, you having access to your email, etc. So I think that's another way to conceptualize it. Sorry to interrupt you, Ethan.
Yeah, no, but I think it's, most of our models still use clinical staff as an adjunct to the physician who's doing the service. So there's still a clinical staff part. And then you can, in some ways, translate some portions of real estate, although not all, into platform costs. because the real estate doesn't go away, because most of us, again, do provide services in real estate also. And so it's really net new costs
Yep.
that are, for most health systems of the size of people you have on this call. I'm not going to, again, divulge secrets here, but it's several $1 million per year in platform costs alone. And that doesn't even talk about the people necessary to operate and support it.
Got it. Perfect. No, I appreciate that additional insight there. Just watching the time here. I know Dr. Shaya, Dr. Berenson, we've got both your hands up. Hopefully we can, I would love to integrate all the questions, and hopefully we can integrate those comments and questions as we shift gears. I do want to make sure we have a little bit of time to cover the code lists. And really, let's start. I'm going to take these a little out of order given the conversation, how it's gone. I'm going to start with this. Let's start with the second one. So we've talked about the methodology for defining the codes for the starting point, right? Of how we identified what codes to include, the service, the specialty types, the categorize it, the E&M codes. And having this be the starting point, again, with the idea we're going to narrow it down based on the actual utilization. We'll certainly eliminate some of the older codes we would expect. But I want to get feedback from the group more generally. Does this approach seem reasonable? Are there code categories? And I direct you to what we send over, the consolidated categories tab of the workbook that we send over. Are there certain categories that we're missing, or certain categories that we think should be excluded? Want to get general feedback and thoughts on those two things. So the overall methodology, and then maybe the categories is a way to look at it. Dr. Bosch.
Man, I'm batting 1,000 here for answering your question with other questions. So did you affirm with one of my earlier questions that the methodology indeed was presenting us codes that were gleaned from the specialists and services that you were seeking to present to us? And sorry if I didn't entirely focus on like here was the initial methodology, because you're asking us, do we approve of the methodology? And I'm scratching my head with I'm not 100% certain with the methodology that was used to present us with that list of codes.
Sure. Let me help with this. I'm going to switch what I'm sharing.
Yeah, and while you're doing that, I'm going to say a consolidated list looks reasonable, but I did have a question that I think is a practical one and a methodologic one as well. At least for in the consolidated list and in primary care, you have one category of codes for exclusion. It was sorry, I'm going to get the name
Care
wrong.
plan oversight, is that so?
Yes, care plan oversight. And I was going to ask, have we, maybe I missed this in some of the reading material, why that as a category is considered for exclusion, or if we had a methodologic approach for, we would consider excluding codes, if they were like this or, some other definition, and maybe that's here, and I didn't see that.
No, that's right. So that's why I wanted to pull this up. So we did describe the process here. The care plan oversight services, again, we're not flagging it as it will be excluded. That one in particular, looking at the descriptions of those codes specifically, talked about services when a patient isn't present. And we didn't, again, it's a unique service compared to the nature of some of the other services that were included in the HCPCS, which is why we flagged that as one to potentially exclude. But again, this isn't necessarily the list. This is the list that we wanted to present for discussion and get feedback. We feel like it's most of the way there, and certainly something that we could use and have used for other purposes. But given the insights that all of you have, we wanted to get the feedback before we finalize before we finalize the list. So did that help?
Yes, it did. Yeah, and thank you. I mean, this looks reasonable.
Perfect. Dr. Shaya.
Forgive me if this question is only for me, but it would still be helpful for me to get that orientation. I do want to go back to what Dr. Booker asked earlier. It is still my understanding is that we're not really looking at codes, E&M codes or any codes in the outpatient setting. We are truly looking for to evaluate the chapters and the bills that allow the extension of telehealth services and comparing those. So the recommendations relating to telehealth services as they compare to in-person services. So in other words, we want to take what telehealth services we can provide and then evaluate those in comparison to what would have happened or what their value would have been if they were provided in person.
Right.
Am I correct? So
Yes.
we're
Yep.
only focused on telehealth visits, not in-person visits as such, just telehealth visits, but using in-person visits as reference, let's say.
Yeah, so yes, so we need the in-person for the comparison to help evaluate this and look at how does telehealth compare to those the in-person visits, but then also looking at maybe the subcategory there. And the reason we have so many is so we can kind of do the analysis at different levels, but telehealth versus in-person, but then also looking primary care telehealth versus primary care in person, right. Behavioral health telehealth, behavioral health in person.
And there are things there as relates specifically to behavioral health, but maybe also primary care that is very important to focus on is audio in telehealth, audio only versus audio plus video. That we need to understand also the value of those and whether or not there are differences. And that is why I think it leads me back to say it's going to be a code by code evaluation. So electroconvulsive therapy is not relevant. Neuropsychological testing may or may not be relevant. I would defer to Dr. Berman and his team to inform us a little bit more on that, whether or not technology is evolving with validation of neuropsychological testing remotely. But it is ultimately a code by code assessment to try and really answer those nuanced, very nuanced questions. And let me well, I don't want to stop at that yet, but the point that I also want to make, following up on also Dr. Booker's, Dr. Hughes, and everybody else, I think it is very important for us, if we step back, to not really think in terms of visit evaluation, but really patient care, because the person providing the visit is not providing that visit in isolation, just like Dr. Booker said. You have an entire system that is supporting and putting out the costs to provide that, and it is never going to be telehealth only or in-person only. So the costs are combined for all of those. You see the patient today by telehealth because that's appropriate clinically, but you tell the patient next week, I need to see you in person because that is what's appropriate clinically. And all of those are part of the conversation.
Perfect. I appreciate that insight, Dr. Shaya. Dr. Berenson.
Yeah, this is a question I haven't looked carefully at the legislation. Does it use a definition of telehealth that is similar or the same as Medicare's, which is that these are services that are directly comparable to an in-person service? It excludes, in other words, it excludes all the communication that primary care docs do with patient portals and phone calls and texts and all of that. That's not telehealth under this under what we're doing here.
I would have to go back and validate, and then that's a takeaway for us to confirm that.
Yeah, I mean, it goes back to my original point is that, again, I'm not going to speak for behavioral health. I suspect it wouldn't be quite the same, but primary care spends a lot of its time in these forms of communication that are not considered telehealth, and they are not paid for.
We do exactly the same, Dr. Berenson, and sometimes even more as we have to manage our patients all the way through. To your point, that's a very, very important part of behavioral health.
That's what I was hoping you'd say, because I think that has to be captured in any kind of study like this.
Absolutely.
If it's not telehealth, I think I personally find a distinction between audio only and video sort of silly.
Totally.
On a
Totally.
Zoom call and you turn off the camera, is that a video call or is that a phone call? I mean, it's arbitrary distinctions. And when I practiced, a lot of the most valuable stuff I did was just a phone call with a patient 3 days after their visit to see whether the treatment is working or whatever it would be. None of that is compensated. And that's why some of us are recommending that we consider the Medicare physician fee schedule not a fee-for-service fee schedule. That could include capitated like payments for all of those small ticket items that can't be paid fee-for-service because they don't have this, they're not worth enough to do a fee-for-service payment. The billing costs would dramatically exceed the fee, and that it should be paid for in a different way. And there are precedents in the fee schedule for bundled payments of various kinds. And so I just would hope that somehow that could be sort of factored into this, that the available codes do not cover the waterfront for what sounds like either behavioral health or somatic health provided by primary care docs.
Great, appreciate that insight, and that is, just thinking more broadly about the work that we've done when it comes to reimbursement. One of the limitations we have often is relying on the claims data to do the analysis, which, to your point, doesn't always capture all the services that are being provided, unless you are looking at a capitation type reimbursement approach, where then everything that's done is just reimbursed under a capitation. So I can empathize with that and trying to make the most of what we've got available there, and that is an important consideration. Dr. Bosch, why don't we take your comment or question here to wrap us up, and then I'll share some closing thoughts, and then I will close this so that everyone can get back. I know we're right at our time, and I want to make sure we respect the time that all of you have given us today. So, Dr. Bosch.
Yep. So teeing off of what Bob said and trying to remember what is it that we're supposed to be looking at today. I'll again use the word payment system as opposed to reimbursement system. Payment system is very broken when it comes to, at least in my opinion, appropriately providing value for patients, beneficiaries, as well as clinicians and certain specialties, maybe more so than others. That to me, I thought was kind of out of scope of our work here. We were more focused, and I thank Ethan for kind of reining us in a bit and saying, remember that there is a focus to the group. It's looking at telehealth compared to, and I like a broader term than telehealth because, as Bob just pointed out, telehealth historically had a particular meaning, and we're using it now in its during and post-pandemic meaning of what is considered telehealth visits. But would the alternative, if we didn't do this work, be funded, paid for telehealth visits? They would no longer be covered as part of our work to kind of pin a value and a payment to continuing non-visit based or e-care telehealth, I guess is the term that's in use now, is one of the concerns that if we were not able to come up with a shared sense of adequate payment levels, that telehealth is on the chopping block. I mean, we're not going to solve the problem, I think, of how to create a fairer payment system that appropriately rewards non-procedural care. But I think that's out of scope for this group. Right?
Yes. And David, I saw you come off mute. I didn't know if you were going to comment on that or if you wanted me to.
Well, so I would say that, we go back to the legislation, and, our job here is to provide recommendations related to payment parity for the delivery of healthcare services through audiovisual or audio-only telehealth technologies. And that's really the scope. It is not up to us to sort of imagine what the legislature might do in the next session or so. But I think most of us here, if we had to put our money on a number, would say that it's probably highly unlikely that telehealth would just essentially disappear.
Thanks, David.
Sure. And we can give you links to the legislation if that helps, if anyone wants to take a look at it.
Yeah, no, those were sent. I just haven't had a chance to read it yet.
Okay.
Perfect. I do appreciate everyone's time, and I know from I think I can speak on behalf of me and Stoddard and Matt collectively. Appreciate the insights that you shared. As I'm looking through my notes, some of the considerations that we discussed in terms of the definition of what adequacy is, had some really good insights and thoughts that we'll be able to consider as we're doing the work, and then also approaches for fine-tuning the codes. Obviously, we do have it built into our process to look at the data and whittle down the list, but then, a few of you specifically shared, the idea of looking at code by code to make sure that it is a comparable code for a telehealth visit as we're building out that comparison. I think was a great insight. And I do appreciate the thoughts and everyone speaking up, because this effort here and the time we took this last hour and a half, I really do think is going to help us refine and improve the report and analysis that we're doing, looking at this important topic. So that's all I have. David, I'll turn it back to you if there's anything you want to have a conclusion here.
I just wanted to say, make sure we covered a couple of the comments we heard about looking at the frequency of the code utilization, which would help decide how much time and energy to spend on codes that are seldom utilized in their view.
Yep, absolutely. And that's the plan. I guess the one follow-up is, if you were to look at this, if you had thoughts on the consolidated categories at this point, we'd welcome additional thoughts. You could email those to me. I think I sent everyone out the material. You have my email address. And then, as we discussed earlier, there will be a follow-up discussion after we've had a chance to get in the data and narrow down the code list, where we'll be able to revisit and look at the details a little bit more.
And Brett, I just want to thank the participants. A lot of great informative discussion, lots of thought questions. This is exactly what we were hoping we would get. And I did want to give our executive director an opportunity to make any last comments.
No, I don't really have anything more to add. I want to go and review the first 45 minutes of the meeting that I missed, but I want to thank everyone for, it's clear to me that there's been a lot of thought that went into preparing for this meeting, and really useful comments throughout. So thank you all for taking some time out of clinical care to help us today.
Okay, everyone have a great rest of your week. Thanks for your time.
Thank you.
Thank you all.
Thank you. Bye.
Bye-bye. Thank you.
Thanks.